Assalamu alaikum wa rahmatullahi wa barakatuhu. Respected orthodontists and my dear friends, we are back with video number 3, which will be an ice-breaking session. Present is an interdisciplinary case where we require other specialists, orthodontists, for the case completion. And I would like to thank my senior orthodontists from Australia, Europe, Africa, and some parts of Middle East for their interest in these videos and encouraging me to make more videos like this. Now, coming back to our case, but before that, I want to make an announcement that those postgraduate students and orthodontists from India or abroad who want to join my master class and want to learn advanced orthodontics can DM me so that we can frame out the or we can make highlights for the event. Now, as this case which I am going to present today is a case which require an interdisciplinary approach where I need a periodontist, I need a prosthodontist, and predominantly an orthodontist who will be handling this case. Now, this case is the case of a 25-year-old female with skeletal class 2 and space dentition, which require an interdisciplinary approach. These are the photographs, these are the smiling photograph, and this is the frontal photograph at rest position. The main concern for this lady was her smile. As you can appreciate that the smile which she is presently having once we start this case. This is the intraoral photograph, occlusal photographs, right buccal and left buccal photographs. Now, if we are going to see the smile arc, if we try to see her smile arc is flat because she is having a flat smile, and once as already she was having an isolated cleft lip for which she undergone for a surgery few years back. Now regarding her smile, she is having a non-consonant smile arc because her lower lip is not touching her upper incisors. The reason is that because she is a skeletally class 2 and a lot of pressure on the oral musculature, which causes the lower lip to go down. That's why we can see that the lower lip is not touching the upper incisors. So what we need to do, we need to retract the upper incisors, we need to deprogram her muscles, and a lot of things we need to do in her. Now coming on her profile, she is having a slightly convex profile and her lips are incompetent at their visible here, the incompetency. A nasolabial angle of 60 degree, and the mentolabial sulcus is deep, which shows that the lower incisors are proclined and the musculature in the perioral area is tense. So what we need to do, we need to retrocline, we need to correct the axial inclination of the upper and lower incisors. So this deep mentolabial sulcus can become shallow. Now the overbite, ideally the overbite remains 2 to 3 mm. The overbite is 1 mm because of excessive proclination. This is shown by a color. We can see only 1 mm of overbite is there. And a recession of 4 to 5 mm up to mucogingival junction. The recession is 4 to 5 mm as per class 3 Miller classification. This is from the classical textbook of Carranza, which is the main book of periodontics or periodontology, According to the Miller classification, this comes out to be 4 to 5 mm of mucogingival junction. We don't have the free gingiva, we don't have the attached gingiva. The whole apparatus has gone down, and we can see it has come to 4 to 5 mm to the mucogingival junction. It's like 3-1 and 4-1. Now regarding the mobility, if we try to see how mobile this tooth is, if we try to move in the lateral dimension or in the horizontal dimension, in both the dimension, according to Grace and Smiles, it came out to be grade 1 mobile. It was more towards to grade 2 mobile, because the apex of this tooth was more off towards extruding type of force was coming when we try to move these two teeth. Of course, the diastema of 7 mm. When we try to see the upper midline, which is concordant with the facial midline, lower midline cannot be assessed because of a 7 mm of diastema. Molar relation bilaterally is class 1, and the thing which an orthodontist need to know is the things which are normal. We need to maintain this normalcy till the end of our treatment. If this class 1 molar relation is not remaining class 1 molar relation, that is the failure of an orthodontist. It means there is an anchorage loss. So there are different ways by which can overcome these things. So what is normal, it should remain normal. That is the key to success for a case which need to be done in a perfect manner. Class canine with a class 1 relation, overjet of 1 mm, and occlusally it's an ovoid shape upper and ovoid shape lower arch. Generalized rotations in upper and lower arch. Diastema of 7 mm in the lower arch. And it was not that the that the frenum, that the labial frenum was not at a position, not at a papillary type of frenum, not as a frenum which was very highly placed. The frenum was at the normal position, but the reason why this diastema is, we cannot assess why the reasoning for this diastema was. So spacing were 1, 2, 1, 3, and we have a grossly decayed 1/6, and 2/6 was restored. Now coming to an important diagnostic aid, which is bread and butter of orthodontics, I say that's the sphelometrics. Now let us test this case on sphelometrics. Now regarding the width appraisal shows 4.2 mm. So it's a skeletally class 2, because in width appraisal we are not taking the cranial base. It is a locally drawn comparison between the maxilla and mandible, so which gives us an inference of that this is a skeletally class 2. Regarding Steiner's, SNA of 88, SNB of 81, which gives us ANB of 7 degree. So it's a skeletally class 2. When we try to see for the profilogram, the blue color shows us that's the norm for the patient, and the red color is the patient itself. So we can appreciate that the green color is showing that the maxillary component is a bit ahead, and the mandibular lower incisors are procline. We can appreciate in the purple color, and the green and the red color signifies that a predominantly horizontal grower. So we need to correct these things. So a horizontal growth pattern of GOGN to SN of 15 degree is there. And coming on to the Steiner's, upper incisor to NA, which comes out to be 8 mm. So forwardly placed upper incisors, 24 degree of upper incisor to NA. Lower incisors lower incisors to NB comes out to be 10 mm. Norm is 4 mm, but a 10 mm means that 6 mm lower incisors are ahead from the basal bone of mandible. Of course, the lower incisors are 43 degree. From 24 or 25 degree comes out to be 43 degree. So a lot of proclination in the lower incisors. IMPA of 116.7, so it's a proclined lower incisors. So coming on to the soft tissues, if we see the Steiner's line, upper lip to lower lip, upper lip is almost 2 mm, which seems to be normal. Lower lip comes out to be 4 mm because of proclination. So protrusive lower lips are there. And nasolabial angle of 60, which is an acute. We need to increase it by retracting the upper incisors. Now this is the pre-treatment OPG of the patient. Here we can appreciate this is a grossly decayed 1/6, and we have spacing distal to lateral, and this is a horizontal bone loss. Patient is having a horizontal bone loss. So if we try to diagnose this case, if we try to make a diagnosis of this case, this is a case of 24-year-old female with skeletal class II on account of prognathic maxilla and orthognathic mandible, predominantly horizontal growth pattern with class II malocclusion with Davies type 2 having lower midline diastema of 7 mm, along with gingival recession and bone loss, reduced overbite and overjet with proclination of upper and lower teeth. Now regarding the problem list, what the Graber Van Esdaal in his classical textbook says, that problem list is a differential diagnosis where treatment planning is made. So we need to keenly see the problem list and accordingly pursue for our treatment planning. So patient is having a convex profile, we need to address that. We have proclined upper and lower incisors, lower midline diastema is there, decreased lower facial height, horizontal bone loss in lower anterior teeth. Now we need to address this horizontal bone loss. According to the Graber Van Esdaal, chapter number 22, the periodontal and orthodontic interrelationship, there are conflicting results regarding the horizontal bone loss, because whether we try to intrude the teeth, there can be more amount of resorption, or there can be this horizontal bone loss be transformed into vertical bone loss. So now as I go on my presentation, we will see how we have dealt this case in our mechanics. So we have incompetent lips, we have acute nasolabial angle, grossly decayed 1/6 and spacing in upper anterior region. Now our treatment objectives, we need to have a balanced profile, we need corrections of upper teeth, we need to correct the midline diastema and horizontal bone loss and gingival recession, which makes this case very challenging, that how to deal with these two types of problems, retracting the teeth and to maintain the class 1 molar relation bilaterally. Mechanics we started with. Now these are the occlusal radiograph, and patient was not sure about going for an implant in the 1/6 regions. We kept this to have the bone. She wants to go for the implants after the completion of the treatment. So this is a space closure by a vertical loop. Space closure was done by a closing vertical loop, and the interesting part in this case is that this closure has been done in a translatory fashion. There is no tipping of the lower incisors, a bodily movement, and even maintaining the class molar relation as class 1, and there was no further recession. Ideally, if we see this case, most of the orthodontists will be of the opinion that we should go for the extraction of these teeth and then we can restore it by a prosthesis. But I took this challenge and I tried to go for this space closure by keeping the force level, moment to force ratio very less, so that the bone resorption should not be there and no further recession of the gingiva should be there. Right buccal, left buccal, we can see the molar in class 1. Then later on, I went to go on for a TAD for the unilateral protraction. I tried to close this space by putting TADs, but there were a lot of side effects with this. I tried to give the torque in the wire, but there was a lateral open bite. So I stopped the protraction, with the TADs and of the posterior premolars. And later on, I tried to go for the loop mechanics, as I love to do the loop mechanics. So this is the space closure bilaterally by a T-loop and a closing loop on right side. So this is the photograph showing that the recession has not progressed. There is no bone loss, and surprisingly you will see that in the OPG this horizontal bone loss has been converted into a vertical bone loss where an angular defect has been created here. Later on, I used class 2 elastics to settle this case. This is settling with class 2 elastics. So now coming with the perio-rehabilitation, where the periodontist roles come and we go for measuring the height, and later on this was a free gingival graft which we put, and almost 5 to 6 mm of recession, and we use the masticatory mucosa. We use the masticatory mucosa of the hard palate to get this graft, and we grafted this and harvested this in the lower anterior region. These are the photographs, and this is showing with the suture that we put this graft. No bone, only the graft was put. No bone was put in the defect, because we thought that this keratinized gingiva will be sufficient for this, because it was angular bone loss. The horizontal bone loss got converted into the angular bone loss or the vertical bone loss, but still, according to periodontist, according to his expertise, they told that we don't require to put a bone graft and just go for the free gingival graft. So later on, this is the case after removing the brackets, after debonding, and we restored, and the patient finally was not ready for the implant, so we went for the zirconia bridge. Now comparison between the pre and the after completion radiographs. Now this is the pre-treatment and this is the post-treatment. Here we can see the horizontal bone loss, these red markings, and this is the yellow markings. We show a clear-cut alveolar bone which is leveled, and here we have an angular defect, and the horizontal bone loss got converted into a vertical bone loss, which we need in this case. And we put the retainers, and later on prosthesis we put here for zirconia. This is the SNA of 88, it comes out to be later 87. Then later on SNB of 81, SNB of 82 in the post-treatment. So ANB got reduced from 7 degree to 5 degree. Upper incisors were 24 degrees, so we have retracted them. We have taken them back, so it comes out to be 18 degree now. And lower incisor linear measurement shows that it was 10, now it's coming out to be 7. And the lower proclination from 43 to 35. Now we have retroclined the lower incisors, we have done lingual dumping of the lower incisors, and according to Grabber, he says that the tipping movement and the intrusion movement, there are conflicting articles. It can worsen the case. More amount of bone loss can occur. But Alhamdulillah, this case settled well. There was no further bone loss. And the profilogram showed that the green color, which we need to correct, it has decreased in the post-treatment, and the lower incisor similarly. And IMPA changing from 116 to 100 degree. So almost a 16 degree of change. Now the width appraisal from 4.2 to 2. Now if we see locally, the maxilline mandible, we have tried to decently try to maintain a normal amount of width, that's about 1. And the soft tissue, the lower incisor, the lower lip from 4 mm to 3 mm and upper from 2 mm to 1 mm. And the mentolabial sulcus, which was very deep, it's turning out to be shallow. And nasolabial angle from 60 to 75, which is decent. The norm remains 90. This is the frontal view. Now we can see the change in her life, in her smile. This is the work of an orthodontist. The orthodontist is known for this, for delivering smiles. And we should be proud that we try to do these mutilated cases and try to settle them in a perfect way. And this is the 3/4 smile view. This is the profile view, where the lips have become competent. And the deep mentolabial sulcus becomes shallow mentolabial sulcus, because the proclination we have addressed in an excellent way. Because of that, the lips became competent and the profile got better. More towards the diastema closure, showing the translatory movement of the teeth. You need to address the biomechanics in a perfect way. You should be having insight how to deal with the mechanics, how to control the moments and forces when there is a lot of recession and bone loss, because putting a greater amount of force will further worsen the case. So balancing the moment of force and moment of couple on an Australian wire, 016 round Australian wire, was great. And by this we settled this case. And this is showing the gum adversal. And the molar in perfect class 1 as it was before, no changes in that. And we have closed the space with loops. Loop physics was used in this. Similarly on right side also. This shows that the zirconia prosthesis and the graft, free gingival graft, which was taken from the palate, and the retainers and the closure of this diastema. This is the non-consonant smile, and now this is a consonant smile, where we can see the lower lip is touching the upper incisor tips. So this we have done by 2 ways. We have retracted the upper incisors and we have relaxed, we have deprogrammed the musculature by retroclining the lower incisors. So this is the smile which patient wants. This is the 3/4 smile. This is the oblique view, pre and post, and the profile view. So this is the profile. Now these are the intraoral photographs. Right buccal, left buccal, frontal, occlusal. Class 1 molar, class 1 canine. lingual retainers in place. Now coming on to our final test. This is the final test for an orthodontist, even in postgraduate examination. This is the test where he need to pass for the superimpositions. Now regarding the superimpositions, now we can clearly see that the upper incisors, they have got retracted. Lower incisor, there is lingual dumping of lower incisor. There is a proper over jet and over bite in the final position of incisors and molar, and also the mandible and the increased facial height. And if we go for the composite analysis, we can see that not much of the skeletal change, because in adult you cannot do miracles by changing his or her skeletal parameters. Now SNA, which comes out to be 88, and the present is 87, SNB 81 to 82, so a change of A and B is 5 degree. So we have tried to come to a norm which is approx the A and B of 2 to 3, we are there like A and B of 5. The upper incisor by 24, now it's coming to be 18. Upper incisor to NA was 8 mm, it's coming out to be 3 mm. It means we have retroclined the upper incisors and we have bodily displaced them up to 2 to 3 mm. Lower incisors, a lot of changes, because the mechanics which we use was having to shrink the lower arch by lingually dumping the lower incisors and maintaining the molar relation as such as class 1. Now lower incisor to NB from 10 to 7. Nasolabial angle from 60 to 75. From acute, we are trying to go to obtuse side, 75. And upper lip, lower lip, we maintained from 4 mm to 3 mm, it got further better, and IMPA from 116 to 100 degree. So these are the cases which are very challenging because of periodontal issues, and we need to be very calculative that can we save the tooth or we cannot save the tooth. Our diagnosis, treatment planning, and biomechanics should be very much quantified, and it should not be throwing arrows in the dark. So this was the presentation which shows an interdisciplinary approach where an prosthodontist, periodontist, and an orthodontist worked as a team, and we settled this case, and we gave the beautiful smile to this patient by addressing all her issues. Now I will be coming next month with a new case which will be more challenging than this one, and till then stay connected with Dr. Junaid. Assalamu alaikum wa rahmatullah. Barakallahu feek.